Third webinars will be titled The Mastering in HFpEF from Clinical to Treatment. And this webinar will be chaired by me. My name is Vebiona Kartini Prima Putri. I'm a cardiologist from Indonesia. And then Dr. Julian Kenrick from Singapore. And we have a distinguished panelist, Professor Andrew Coates from the Heart Research Institute Australia, and Raza Ezman Raja Shariff from Malaysia. This webinar will be started with an introduction about heart failure preserved ejection fraction with the title of HFpEF, Can We Start Relaxing, by Dr. Gary Gan from Sydney, Australia. And we will have two case presentations. The first one is from Dr. Hawani Sasmaya Prameswari from Indonesia. And then the second one is from Dr. Henry Chan from Australia. This webinar is copyrighted by the APSC, and this webinar is live streamed via APSC Facebook and YouTube as well. And CME points will be submitted for those who are connected throughout the whole duration, and you will receive your certificates of attendance upon completing a survey. And then it will be sent by email after the webinars. Now let's get started. For our first presenter, it's Dr. Gary Gan. Dr. Gary Gan is a clinical lead of heart failure service in Westmead and Blacktown Hospital, Sydney, New South Wales, Australia. The presentation will be titled Heart Failure with Preserved Ejection Fraction. Can we start relaxing? And Dr. Gary, you can start sharing your slides and present. Please, Dr. Gary.
Hi, everyone. Can you see my slides?
Yeah. Yes,
okay. All right. Okay. Well, good evening, everyone from Sydney, and thank you, Vebi, for the very kind introduction. I know most of you must be very busy after your long day of work, so thank you for taking your time out of your schedules to attend our webinar today. So this evening, I have the privilege of speaking about heart failure with preserved ejection fraction, a topic that for the better part of the last 2 decades has been a constant conundrum for heart failure cardiologists, but which is now the focus of newer heart failure trials and pharmaceutical developments. Now, in my talk, I'll first start by going through diastolic heart failure, a little bit of a historical sort of aspect, and concurrently covering the growth in our understanding of its pathophysiology. Then I'll be touching on the evolution of nomenclature in HFpEF before moving on to the phenotypes of HFpEF. Finally, I'll be covering the management of the condition and finishing the talk with a small discussion on heart failure with mildly reduced ejection fraction. I have no disclosures relating to this presentation. So, diastolic heart failure. Now, let's start with the definition of heart failure. Definition of heart failure has changed substantially over the last 2 decades. Traditionally, the condition was defined as an inability of the heart to pump blood commensurate to the body's needs, or to do so only at the cost of high filling pressures. Just remember that this definition was based fundamentally on the presence of congestion that results in the clinical syndrome of heart failure, and that it was actually irrespective of your ejection fraction in the very beginning. However, as we entered the 1990s, the diagnosis of heart failure became synonymous with the presence of reduced ejection fraction, and this was largely because of the major randomized clinical trials at that time, which included an upper ejection fraction exclusion criteria. Heart failure in the absence of a reduced ejection fraction was actually first described in isolated case reports and small case series throughout the 80s and the 1990s. However, the syndrome of diastolic heart failure received little attention until the more widespread use of non-invasive assessments of the ejection fraction, which was the setting stage to epidemiological studies such as the Framingham Heart Study, Helsinki Aging Study, and the Strong Heart Study. Now, here we see a figure derived from one of these large epidemiology trials, the Olmsted County study. The figure you see here describes the secular trends in the prevalence of heart failure in the absence of a reduced ejection fraction. On the left, we see that diastolic heart failure represents almost 30% of the population of heart failure. And alarmingly, the condition was increasing at a rate of 1% per year, even back in the 1990s. Now, This correlated with the increasing number of admissions for heart failure in the absence of a reduced ejection fraction that's marked in red in the figure on the right. But interestingly, there was no difference in the rates of admissions for heart failure with reduced ejection fraction. Now, based on the same study, we also understood that irrespective of whether your ejection fraction are reduced or preserved, the condition was associated with poor long-term outcomes. Further studies evaluating patients with diastolic heart failure showed that similar to systolic heart failure, these patients have a poor quality of life and they live with a significant burden of symptoms from day to day. Now, the distinction between systolic and diastolic heart failure was popular at that time because it conveniently divided the population into two halves that reflected the key pathophysiology that was thought to drive each syndrome. But despite this distinction, there was widespread skepticism of diastolic heart failure in the very beginning, and this was in part driven by the fact that it was very difficult to accurately assess diastolic function at that time, and this skepticism was echoed in the 2001 heart failure guidelines, whereby they described the uncertainty about the prevalence of this condition itself. Now, it was not until 2004, following seminal work by Dr. Ziles, that established the diastolic pressure-volume relationship in these patients, that the term diastolic heart failure became widely accepted. Now, Dr. Ziles showed that compared to healthy young controls, patients with diastolic heart failure actually had impaired left ventricular relaxation and increased diastolic stiffness that was reflected by a leftward shift in the diastolic pressure-volume relationship, so that filling pressures were actually higher at every given volume. Now, in the years following the landmark study, we saw consecutive reports from large population-based studies confirming the hemodynamic changes that we see in diastolic heart failure. But interestingly, there was also growing reports of further structural and functional abnormality in these patients. In this study by Dr. Lam, comparing healthy controls and hypertensive controls without diastolic heart failure, patients with diastolic heart failure not only had higher end diastolic pressures, but in the bottom left, we can see that they also had steeper end systolic pressure volume relationships, greater left atrial sizes, and higher pulmonary pressures, which disturbingly was actually present in more than 80% of HFpEF patients. And by the end of 2010, the basic pathophysiology of diastolic heart failure was established, which is what we still understand of HFpEF today, whereby increased left ventricular filling pressures from diastolic dysfunction leads to left atrial hypertension and remodeling and subsequent back pressure into the pulmonary system with pulmonary, venous, and arterial hypertension. Now, the evolution of nomenclature in HFpEF started around the same time. You see, at that point in time, there was no more doubt that diastolic heart failure was a real condition. However, we really started facing difficulties in regards to describing it. Diastolic dysfunction by itself was not specific or sufficient for the diagnosis of diastolic heart failure, and population-based studies actually confirmed this, demonstrating that diastolic dysfunction was actually commonly present in the systolic heart failure patients. Furthermore, diastolic dysfunction was also present in a large proportion of older adults who were asymptomatic. So moving away from the terminology of diastolic dysfunction emerged the term heart failure with normal systolic function. This term was a bit more neutral and didn't make any assumptions regarding the underlying pathophysiology and could accommodate the mechanisms that extended beyond diastolic function assessments, such as the left atrial enlargement and pulmonary pressures. But with the expansion of imaging technology, however, it soon became quite obvious that normal systolic function was not the norm in patients with diastolic heart failure. And these patients often have reduced longitudinal strain compared to controls. And it also suggested that diastolic dysfunction had a pathophysiological role in systolic dysfunction as well. So knowing this, the term heart failure with normal ejection fraction was subsequently coined, and the emphasis on ejection fraction in this context was practical and convenient, given that a lot of physicians by that time had accepted the ejection fraction and was quite familiar with assessing ejection fractions. There was, however, a lot of controversy regarding the cutoff of what we consider to be a normal ejection fraction. LVEF being a continuous variable with a normal distribution within the general population. So the distribution changes with age and sex, and thus it was challenging to describe a specific threshold that would be normal. For instance, our heart failure guidelines use a cutoff of 50%, whereas echocardiography guidelines uses a threshold of 55% to define what would be a normal ejection fraction. Now, the need to assess this evidence gap was what led investigators to develop the CHARM program. This was an umbrella program with 3 arms, the third of which was the CHARM preserved component that included patients with an ejection fraction of more than 40%. Now, even though the trial was negative, the use of the term heart failure with preserved ejection fraction in this major outcomes trial, along with the continued uncertainty of what was normal ejection fraction, led to the widespread adoption of the term HFpEF that continues until today. So it came as no surprise that in the 2011 ESC heart failure guidelines, that diastolic heart failure was classified as HFpEF. And compared to the 2001 guidelines, there was much less skepticism regarding this condition. And pleasingly, we even saw introduction of a diagnostic criteria for the condition. Now, even though it's now widely used, the term HFpEF has been applied with varying ejection fraction cutoffs in clinical trials, sometimes 40, sometimes 45%. In our heart failure guidelines, we have continued to use a cutoff of 50%. Now, the typical HFpEF phenotype. Based on a large epidemiology studies, the typical HFpEF patient is more likely to be elderly, female, and with a history of hypertension and/or AF. As the population grew and with increased recognition of HFpEF, however, we started to see different phenotypic patterns emerge, particularly amongst different ethnicities. Now, in the Asian Heart Failure Registry, which enrolled more than 1,000 patients with HFpEF, we found that HFpEF patients could also be young, and these younger patients with the condition were more likely to be men who were obese and strangely had lesser rates of AF, hypertension, and even CKD. However, these individuals did have similar changes in diastolic function compared to the elderly with HFpEF. And when we compared Southeast Asian to Caucasian patients with HFpEF, we found that at any given BMI, there was a much higher prevalence of diabetes, despite the younger age and less rates of obesity amongst the Asian cohorts. And what we learned from this is that in addition to the typical phenotype of elderly female with AF, there were specific comorbidity clusters that is highly prevalent amongst HFpEF, and that a one-size-fits-all approach may not be the right way to work in HFpEF, and instead, we needed to try to find a phenotype-specific approach. But let's talk a little bit more about adiposity and weight. When we look at outcomes in epidemiology studies, with increasing BMI, the probability of a bad outcome actually goes down. That is the obesity paradox, whereby obese patients with heart failure are actually protected from a bad outcome. However, when we look at it differently in terms of the waist-height ratio, however, the studies do show a different signal. So in the Asian Heart Failure Registry, the investigators studied the effect of BMI quartiles on outcomes, and they divided the patients into 4 combined anthropometric groups of BMIs and waist-height ratio, either high or low. And compared to HFrEF, patients with HFpEF had a higher mean BMI and a higher waist circumference, as you can see in the figures at the bottom left. Interestingly, when we look at the risk of composite outcome of a death or heart failure hospitalization, this was actually highest in the lean fat group, which is the group with low BMIs, but a high waist height ratio. And so it is actually the lean fat that actually does the worst. But what does this mean in terms of our pathophysiology of HFpEF? Does it mean that the distribution of fat does worse, or is it visceral fat that does worse? And as an extension, could epicardial adipose tissue play a role in this pathophysiology? Now, when we try to quantify epicardial fat, we found that epicardial adiposity to be increased in HFpEF, but thinner in HFrEF. Epicardial fat was associated with greater LV dysfunction by LV-GLS, and more fibrosis on MRI. The increased fat thickness was also associated with worse outcomes in HFpEF, but a thinner epicardial adipose tissue was actually associated with worse outcomes in HFrEF. So this basically gave rise to an idea that systemic comorbidities leads to ectopic fat accumulation, not just in your coronaries, but also around essential organs, and this ectopic fat tissue secreted pro-inflammatory mediators that affected the underlying myocardium, and that leads to downstream diastolic dysfunction. At the same time that we were studying metabolic perturbances, there was also increasing reports of microvascular dysfunction in HFpEF. In the Prima HFpEF study, Sanjeev Shah and his team showed that patients with HFpEF had a high prevalence of coronary microvascular dysfunction. And this dysfunction correlated strongly with systemic endothelial dysfunction, which was evidenced by increased urinary albuminuria and markers of heart failure severity, such as the NT-proBNP and LVGLS. Now, the discovery of these new phenotypes in HFpEF has essentially led us to the concept that there is a systemic manifestation of HFpEF, and that looking at the heart was simply not enough. And so came around the multi-hit mechanism whereby systemic inflammation, iNOS activation, and nitrosative drive stress was thought to drive heart failure with preserved ejection fraction. In other words, patients with a high burden of comorbidities trigger a systemic pro-inflammatory state which impairs the physiology of the endothelium and activates complex pathways that eventually result in stiffening of the ventricle and diastolic dysfunction. The clinical significance of this: it means that we do have to stop thinking of HFpEF as just the heart, but a systemic disorder. And it also means that it opens doors to newer therapies, which takes us into the era of the SGLT2 inhibitor. And this ties in nicely with the next part of my talk, which is management of HFpEF. Now, it's no mystery that compared with the rapid development in treatment of HFrEF, there have been minimal advancements in pharmacotherapeutic options for HFpEF. But this was not due to lack of trying. Rather, it was the result of trials that unfortunately at that point in time didn't take into consideration how heterogeneous HFpEF was. Now, due to the lack of effective treatments, however, it was unsurprising that our 2016 guideline recommendations for HFpEF was basically very uninspiring. Apart from diuretics to decongest, the guideline committee also recommended screening for cardiovascular and non-cardiovascular comorbidities, and if present, should be managed with interventions. But things changed in 2021 with the publication of the Emperor Preserve trial and subsequently the DELIVER trial in 2022. Emperor Preserve evaluated the effect of empagliflozin compared to placebo in patients with HFpEF, and the DELIVER trial evaluated the effect of dapagliflozin compared to placebo. Both trials enrolled patients with symptomatic heart failure with an ejection fraction of more than 40%. Now, both trials were successful in reaching the primary composite outcome of cardiovascular death and hospitalization. However, as both trials were not powered to assess the individual components of the primary endpoint, they performed a pre-specified analysis of DELIVER and Emperor Preserve trials that included more than 12,000 participants. In the meta-analysis of the Emperor Preserve and DELIVER trials, it showed that dapagliflozin and empagliflozin robustly reduced the primary outcome of heart failure hospitalization and cardiovascular mortality by 20%. But importantly, this was driven by reductions in both individual components of the composite outcome. There was remarkable consistency across all subgroups with no heterogeneity across the demographic subsets, measures of heart failure risk, or even NYHA class. And importantly, the SGLT2 inhibitors led to a greater meaningful improvement and a lesser clinically meaningful deterioration in multiple domains of health as assessed by the KCCQ at 8 months. And thus, in the 2023, the Guidelines Committee released a focus update of the 2021 heart failure guidelines, now incorporating SGLT2 inhibitors, dapagliflozin, and empagliflozin in the treatment of HFpEF with the highest level of evidence. And what about heart failure with mildly reduced ejection fraction? Now, earlier we discussed the evolution of nomenclature for HFpEF and how subsequent to the CHARM program, trials started defining HFpEF as an ejection fraction above 40 and 45%. In 2013, the ACC-HHJ decided to coin the term mid-range ejection fraction to describe the population of patients between 41 and 49%. And in 2016, the ESC guidelines framed mid-range ejection fraction to be you could say, an extension of HFpEF. Now, things, however, changed in the 2022 guidelines when mid-range was renamed as mildly reduced, and this group was described more parallel to the heart failure with reduced ejection fraction group in management rather than the HFpEF. But the question that we have is basically, why don't we dichotomize heart failure into two groups, reduced versus preserved, and why did we rename it as mildly impaired ejection fraction? Well, the thing is, with combining patients with mildly reduced and more severely reduced into one group, essentially the guideline committee felt that it would fail to acknowledge the important differences in prognosis, magnitude of treatment effect, and even risk-benefit ratio. Also, this approach gives the most patients the benefit of the doubt, reducing the risk of patients with mildly reduced ejection fraction, especially women, who may be deprived of potentially beneficial strategies. And so preserving the acronym HFmEF, yet reminding clinicians that such patients may benefit from established heart failure therapies traditionally reserved for those who would have more of a severely reduced ejection fraction. Do heart failure therapies work in heart failure with mildly reduced ejection fraction? Well, there is data to suggest that it does, and what we can see here is post-hoc analysis from all our major classes of pharmacotherapeutic agents in HFrEF, and it shows that across the spectrum, there is data that suggests that there is evidence of efficacy as we go up in terms of ejection fraction. It does attenuate once the ejection fraction gets into the higher levels or above 60%. And above all, the SGLT2 inhibitors, remember, do have efficacy across all ranges of the ejection fraction. And so this leads us to, once again, the 2023 focus update of the 2021 ASC guidelines, which now recommends consideration of these classes of medications for heart failure with mildly reduced ejection fraction. So to summarize, heart failure with preserved ejection fraction is a clinical syndrome in which patients have signs and symptoms as a result of elevated left ventricular filling pressures despite normal or near normal left ventricular ejection fractions. It is a heterogeneous condition with different phenotypes that's postulated to be driven by endothelial inflammation and microvascular dysfunction. Just remember that there are now effective treatments for HFpEF, and that patients with heart failure with mildly reduced ejection fraction should be considered for conventional HFrEF therapies due to its potential benefits. Thank you.
Hi, good afternoon, everybody. Thank you, Gary. That was an amazing presentation that took us through the history of heart failure with preserved ejection fraction in a very concise manner. And it's very clear and very targeted, and it was a great presentation. Thank you very much. I don't see any questions in the question box, so just a quick reminder to the audience to put your questions in, and we'll be happy to take them. I might start off with the first question, if I may, Gary. And I think perhaps the first thing is, if you ask the majority of clinicians, the first problem they have with HFpEF, as you mentioned, it's now the most common type of heart failure. It's increasing in incidence. It's overtaken HFrEF, and yet at the same time, it's such a difficult entity to sort of pin down. Diagnosis is a challenge. Majority of the time, the patients have a normal EF. They're a bit short of breath, but the majority of us at our age climbing up the stairs, all of us are going to feel a bit short of breath. So how do you sort of, coming to the diagnosis of HFpEF, what is your approach? The ESC, the Europeans, the Americans have slightly different guidelines. The ACC gave us a 2023 sort of expert consensus as well on how to approach it. What is your approach to the diagnosis of HFpEF, please?
Okay, I guess it does come down to what setting at which I see the patient, But let's assume in a more ambulatory setting with somebody who has, I guess, breathlessness, non-specific breathlessness, there's concern of heart failure because of some lower limb edema. I think in this situation, using echocardiography is essential, but even before echocardiography, I think the role of anti-proBNP would be very useful here as well. With the use, anti-proBNP is excellent in its exclusion, sort of in its power to exclude heart failure. I think if that was negative, then yes, we would be looking at a different cause of the breathlessness. But certainly, if it was positive, I would have a fairly high, I guess, pretest suspicion that this person would have heart failure. and then I would corroborate it with what we see on echocardiography, and not just in terms of the diastolic parameters, but also the other sort of correlating parameters that we just spoke about, such as the atrial size, pulmonary pressures. I think this in itself would give us a very good idea of whether this patient actually has heart failure with preserved ejection fraction. And I think also the history in itself, don't underestimate the history, because most of the time, a lot of us, after years of practice, you have that clinical instinct that tells us when a breathlessness is actually cardiac versus non-cardiac based on the history in itself. So I'll put it all together. That's my step in terms of diagnosing somebody with undifferentiated breathlessness.
Perfect. That's great. Thank you. That's generally my approach as well. Maybe to put you on the spot, because this is something that I don't do, and I just wonder if it's something you do. What about the two HFpEF scores? The HFpEF or the H2FpEF score. Is that something that you use?
I guess I do try to, in clinical practice, I think most of the time our biggest challenge is time. And also, I guess, trying to organize these investigations. Most of the time, a patient walks into our room, we have the clock starts then. And so usually in terms of the scores in itself, I often find that I only have time to actually go through the scores once the patients have left the consultation. We gather all the information that we have, and then we sit down and we use the scores. But at the same time, even with the scores, like I said, most of the time you get an instinctive feel about what the patient actually has. So yes, in terms of the scores, I do feel that they are very useful, particularly when it comes to specific types of specific categories of patients. But the other half of the picture is really, when you assess the patient, whether there's evidence of congestion, whether or not, and then sending them off for, I guess you could say, the typical sort of investigation, the serology for BNP and the echocardiogram.
Perfect. Thank you. Thanks so much, Gary.
Yeah, it's always interesting to talk about HFpEF, because back then people were really skeptical about the HFpEF. I think the hardest part of the HFpEF is how to diagnose, because when we talk about the assessment of individual having shortness of breath with edema, there's a lot of differential diagnosis that in our mind. So I would like to ask Professor Andrew Coates, in a practical clinical approach, if the patient have clinical signs and symptoms of heart failure, especially for the first responders, what is just like a tips and tricks how to distinguish about the heart failure mimics or HFpEF mimics, or is it really the HFpEF? And as a cardiologist, maybe we can even as a cardiologist, I think we already did echo and then check the NT-proBNP, and then the score was high, but sometimes that we are not sure, is it really true HFpEF, or it's HFpEF mimicking, or even it's a heart failure mimicking? Maybe Professor Coates. Professor Andrew Coates? Or maybe Ezman, do you have any experience in this?
So just to repeat so that I got the question right. So you're asking how best to differentiate between HFpEF, the actual what we think is the actual HFpEF or garden variety HFpEF, or whether they are mimics. I think that the ESC sort of outlines it really well, as well as the American guidelines as well, with regards to your initial approach to heart failure per se. You use your clinical assessment, etc., but you also corroborate that with things like NT-proBNP or BNP, depending on your institution. And the echocardiogram is really, at least in my view, really vital, because not only does it tell you certain things that help you with the score for ESC HFpEF score, but also it tells you other potential mimics. So valve disease, for example, hypertrophy, for example, as in hypertrophic cardiomyopathy, for example, or other things like strain, which can help you with ruling out mimics such as amyloidosis. So you don't go down the wrong path per se. Because at least in my practice, we have had cases where people think it's, Band or HFpEF, patient gets started on SGLT2s or what we call the HFpEF cocktail, but they don't get well. And after relooking at the imaging, relooking at the history, etc., it was pretty clear cut an amyloid case, for example. So there are ways, and I think the guidelines, both ESC and the American guidelines, make a brilliant effort to remind people to look out for mimics. The American guideline per se, ruling out mimics quite near the top before you start with all the other investigations. So I hope that answers the question.
Yeah, Professor Coates, we are talking about how to differentiate clinically whether it's a heart failure mimics, HFpEF mimics, or it's a true HFpEF, especially for the first responders. Maybe they can usually confuse, or as for the cardiologists as well, that we are sometimes confused that whether it's really a true HFpEF or it's a HFpEF mimicking a disease. Do you have any idea, Prof?
Yeah, look, it's very interesting, and I really enjoyed Gary's talk. So you have to think in terms of whether you take a big picture view, which is how common is heart failure with preserved ejection fraction, in which you need to use criteria which are widely applicable. So the universal definition of heart failure sort of establishes that you need signs and symptoms, an abnormality of the heart, and confirmation of hemodynamic stress, such as end-terminal pro-BNP elevation. And in that regard, HFpEF is fairly easy to diagnose. But when it comes to an individual patient, as you say, there are mimics of conditions, and you want to exclude those. So I look upon the American HFpEF algorithm and the European HFpEF algorithm as completely different. The American basically is a risk matrix for how likely HFpEF is. It includes things like being overweight, being elderly. Clearly, they're not diagnostic criteria. They're just saying if you screen a population, these are where the HFpEF patients are more likely to be. Whereas at the other end, the European guidelines, the European HFpEF score requires you to go to enormous investigation for an individual patient, including invasive hemodynamic assessment, which is not practical in most cases. So I think they're two extremes of how we'd use it. And I prefer to have a clinically more applicable definition, which is the definition done by the trials. So the two SGLT2 inhibitors, Deliver and Emperor Preserved, are the only two trials that tell us precisely how to treat these patients. And provided a patient satisfies those criteria, which were relatively straightforward, then on average, the patients will benefit. Now, clearly, I accept if you have other information, such as amyloid or other conditions, you might go in another direction. But I think taking a simplified approach to diagnosis in terms of what therapies you do, in terms of actionable actions, I think those clinical trial entry criteria are the most important.
Yeah. Oh, it's very insightful. Okay. I think we can have more discussion after we have a trigger case from our next presenters. Now I will welcome Dr. Hawani Sasmaya from Indonesia to present our first case. Maybe Dr. Gary, you can stop share your slide so Dr. Hawani can share her slide.
Yes.
Okay, Dr. Hawani, please.
Okay, thank you so much, Dr. Febi, for your introductions. And it's an honor for me to be part of this webinar. And it's always interesting and intriguing to discuss about heart failure preserved ejection fraction. So that's why I would like to present two cases. But I think before we talk about the case, actually, Gary already mentioned before about this. So there are different facts in Asian population, especially Southeast Asian populations, about the characteristic of HFpEF patients. In Asian populations, especially Southeast Asia, the patients tend to be younger with a high mortality number. Actually, this has become our responsibility together to reduce the mortality number for our patients. And it's usually related to multiple comorbidities, especially type 2 diabetes and also hypertension. And this is one of our study in Indonesia. Though we know that there are many guidelines and also recommendations to diagnose heart failure preserved ejection fractions on also the treatment, but somehow Based on our study, there are still 37 of respondents with this, which is mainly a cardiologist and also internists, show that they are still not really comfortable in terms of diagnosing and also treating patients with heart failure preserved ejection fractions. They still think that in diagnosing and treating patients with HFpEF is quite challenging. So I will move to the first case. This case is 64 years old female, referred to the heart failure clinic, just recently discharged from the hospital. The patient still feel dyspnea effort, especially when climb one story, with also have a minimal bilateral lower limb edema, with the cardio risk factors, hypertensions, and the patients also have a past medical history of osteoarthritis, and this is the previous medications. And based on the physical examinations, these patients considered as overweight with a high blood pressure. And also we can see there are signs of congestions in these patients, and there's also a mass at her anterior neck. So based on the ECG, there's an atrial fibrillations with a poor airway progressions, and the lab results, we can see there are increase in the NT-proBNP and also thyroid abnormalities. And from the echo, we can see the patients have a dilated LA, RP, and also concentric LVH with preserved ejection fractions with a global normal kinetic, with LV diastolic dysfunctions, and also high probability of PH with a normal RP systolic functions. And actually, if we do step by step in diagnosing HFpEF, the first is sign and symptoms of heart failure. We have it in these patients, and then the patients also have a preserved ejection fractions. And actually, this case is quite a clear case. It's a straightforward case because these patients have a sign and symptoms of heart failure with a preserved ejection fractions, and these patients didn't have any comorbidities that may show sign and symptoms that's similar with the HFpEF. So what we can do is actually we just trying to find whether there's any structural abnormalities or functional abnormalities that we can find in these patients. And yes, indeed, I echo Prof. Coates' opinion about actually we can also use the study inclusion criteria to diagnose HFpEF in a very straight cases. And we can also use the guidelines. We don't need to jump with a scoring system for every kind of patient that we suspected HFpEF. So like in this patient is very clear-cut patients. So the patients have signs and symptoms of failure, and then the ejection fractions was preserved. So we can just use the guideline recommendations because the guidelines recommends a simplified pragmatic approach. So in these patients, we're trying to find whether there's any structural abnormalities. Yes, the patients have a thickening in the LV mass, and then also high LAFI with diastolic dysfunctions with high NT-proBNP and also increase in the TR velocity. So yes, we can conclude that these patients have a HFpEF. But however, sometimes we can also find patients with quite multiple comorbidities, and it's very difficult for us to find out whether the symptoms is related to the heart failure or other possibility. We know that the dyspnea also can caused by pulmonary disease, and edema can also caused by renal failure or liver failure. So in those kind of patients, I think better if we use the pathway to diagnose HFpEF to increase the accuracy in diagnosing HFpEF. So like what already discussed before, in those group of patients, we need to find out whether there is any non-cardiac mimics like kidney disorder, liver disease, CVI, or pulmonary disease. And then we can go through whether the patients have HFpEF mimics or not, like we already discussed before. And then to increase the accuracy in diagnosing HFpEF, we can use the scoring system as well. But actually, why do we need scoring systems? Because we know that the gold standard to diagnose HFpEF is actually the increase in the LV-EDP. But again, it's an invasive procedure. So, however, the non-invasive findings usually show a modest correlations to LV-EDP itself. So we need comprehensive non-invasive imaging modalities to know whether our patients have HFpEF or not. That's why we need a scoring system. So the scoring system I use in these patients, actually, I already diagnosed these patients as HFpEF, but I just wanted to know whether the scoring system can help me to diagnose these patients with a HFpEF or not. So we use the ESC scoring system. The score is 5, and then HFpEF score, the score is 6. It's considered as a high probability of these patients to have HFpEF. So basically, scoring system help to facilitate discriminations of HFpEF from non-cardiac causes that can also cause dyspnea and also other conditions. So we diagnose these patients with hypertensive heart disease, chronic heart failure, HFpEF, and YG class 3 with atrial fibrillation, normal ventricular response, hypertension, hyperthyroid. And the one thing that we need to also assess in our patients is the etiology of the HFpEF, so the step 4. Never forget the step 4. So we can see the step 4 for our patients. It can happen because of the hypertension and also overlapping with the hyperthyroid. So the treatment for our patients, we gave these patients furosemide. We increased the furosemide dose. We gave ramipril and amlodipine that already consumed by the patient, and we add on empagliflozins, and we gave apixaban and refer to cardiac rehab as well. And also the patients get the thyroid treatment from the endocrinologist. And from the follow-up and 3 months and 6 months follow-up, the patient is doing well. And even we repeat the echo, and the echo surprisingly show the FVMI improving. I also repeated twice actually to make sure that is it real. It turns out it's real. And then the ejection fraction is preserved with improving in the diastolic dysfunction as well. And there's also a reduce in the pulmonary hypertension to low probability pulmonary hypertension from previously high probability of pulmonary hypertension. Okay, so the next case, I think it's more challenging, and I also wanted to know, I would love to know the expert's opinion regarding this case. So this case is actually 77 years old male with a history of long-standing ASD. So 77 with ASD. Just 1 year ago, he underwent ASD device closure. But however, the clinician, the previous clinicians referred to me because the patients still feel dyspnea for minimal bilateral leak edema. And these patients also have hypertension for 5 years, for probably more than 5 years, but he mentions it's about 5 years. And then on amlodipine, and the patients also have a COPD on treatment. And the physical examination show high blood pressure with the heart rate 76 beats per minute, irregular with a minimal bipedal edema. And then the ECG showed right axis deviations with the right ventricular strain. The chest X-ray show cardiomegaly with not really clear the pulmonary congestions, and the NT-proBNP was quite high. So we repeat the echo, showed a dilated LA, RA, RV, and also concentric LVH. The ESD actually, the ASD device is in situ and well seated, so it's good. With preserved ejection fractions, with LV diastolic dysfunctions, with a high probability of PH and normal RP contractility. Based on this, then I'm wondering whether this patient actually has a HFpEF, or the patients have a pulmonary arterial hypertension because of the ESD, though we already closed the ESD, or is it because of the lung disease? So in this group of patients, I tried to use the scoring system because we know that the scoring system have very good in terms of included patients with HFpEF, but not that good to exclude patients with HFpEF. So we use the scoring systems. Turns out the scoring system show using the HFpEF score is 4, and H2FpEF score is 5, so it's considered as intermediate probability. So unfortunately, we need to do exercise test. Of course, we prefer to do the non-invasive exercise test before we go to the invasive test. Unfortunately, in our case, there's a fusions of the E wave, and also the patients have atrial fibrillations, though it's a paroxysmal, so it's very difficult for us to do. And the patients also have a poor echo window during the exercise test. So what should we do? To answer my curiosity, we do the invasive hemodynamic, because actually this is a prevalence from invasive hemodynamics in HFpEF patients, especially in patients with image limited during the exercise test, or poor quality of echo imaging that we have in our patients. So in invasive stress test, there are two possibilities that we can do. But actually, the recommended by the guidelines is the exercise test. However, the exercise test is usually need a special equipment, which is our center doesn't have it. So we can also use the alternative test, which is fluid challenge test, though it is less physiologic, but it is less complex and no special equipment required. And in this fluid challenge test, actually, we can just give the patients fluid 500 cc. In 10 minutes, then we can repeat the pulmonary capillary wedge pressure. So in our case, I got the results from the right heart catheterizations before ASD closure. The wedge pressure is actually 12 millimeter mercury. the pulmonary arterial pressure 20 to 21 is not that high, with the PVR is low. So probably it's considered as unclassified pulmonary hypertension because of the flow. But then I repeat the right heart catheterization. So 1 year after the ASD closure, turns out even with resting, I didn't do any exercise test. The wedge pressure is increased to 18. With the mean pulmonary pressure was also increased to 22, though it's not that really significant. With the PVR is still low. So we consider these patients as a type 2 pulmonary post-capillary pulmonary hypertension or type 2 pulmonary hypertension. So we diagnose these patients with, and also confirm HFpEF. So we diagnose these patients as hypertensive heart disease, chronic heart failure, HFpEF, NYHA class 2 with AF paroxysmal, ESD pulse, device closure, and hypertensions. Again, hypertensions. So the treatment for these patients, besides lowering the blood pressure, we also give maybe for the atrial fibrillations and then furosemide, and also we add on empagliflozins in patients also on warfarin. So the step 4, never forget the step 4, the etiology we try to find in here in this patient is most likely related to the hypertension. About the atrial fibrillations, we can debate about this because we don't know whether a chicken or the egg, we never know whether the atrial fibrillations cause the HFpEF, whether the HFpEF cause atrial fibrillation. So basically the hypertension most likely can cause these patients become heart failure. And about the management of heart failure preserved ejection fractions, there are 3 focus, not only symptoms management, but also disease modifying treatment, risk stratifications, and management of comorbidities, because we know that most of the HFpEF patients have many comorbidities, and also non-pharmacological management. This is sometimes as a clinician, we tend to forget about the non-pharmacological management, which is exercise is tremendously important. And luckily in 2023, now we have the HFpEF treatment with class 1 recommendations, which is empagliflozin and dapagliflozins. But never forget the 2B level recommendations that we can also consider in our patients. So the key conclusions in my presentation today: first, diagnosing and managing HFpEF patient is complex yet achievable, and careful assessment of patients' characteristic and phenotype is a key to an accurate diagnosis. Conducting thorough screenings for potential etiologies is crucial in devising effective treatment plans. And last but not least, with appropriate interventions, HFpEF is not only treatable, but can also show marked improvement. With that, I would like to say thank you.
Oh, thank you, Dr. Hawani. Oh yeah, I learned a lot from both of the case. As we can see that the first case, it's a straightforward case. If we got this kind of case
Correct.
in our heart failure clinic, and then okay, diastolic dysfunction, check the NT-proBNP, okay, just give the SGLT2 and the symptomatics and send to rehab, and that's all. And then in the second case, I just
Yes.
wondering whether it's okay, pulmonary hypertension,
Yeah.
HFpEF, or something else, or just because it's a geriatric problem also, that the patient it's already
Correct. 77 years old.
yeah,
Yes.
77 years old, and
Yes.
we have this kind of patient a lot actually. So I would
Yeah.
like to ask Professor Andrew Coates,
Yeah.
what
I
do you
would
think
also
about
hear.
especially for the second case?
Yeah.
Yeah, the second case is absolutely fascinating. And the one thing that struck my attention is the closure of an ASD at the age of 77. So the indication, I presume, was prevent strokes. But given that evaluating atrial septal devices to cause an ASD as a treatment for HFpEF, and we haven't got the final results of those trials yet, they're a little bit up in the air, then clearly the closure of the ASD may have precipitated HFpEF symptoms by elevating left atrial pressure in someone who had a natural decompression. So every time we do something, we must consider the possible consequences of that. And, you may get adverse effects for something that's otherwise indicated for prevention of stroke that may actually elevate the potential for symptomatic elevations of atrial pressure. Clearly, we need to do a lot more in terms of evaluating pulmonary artery pressures, pulmonary vascular resistance, and that's an area where we still do very poorly. But I like to think simplistically that, when you're treating a patient, first of all, you say, do they fit into a category where there's a clinical trial that tells us what we should do? So if someone satisfies the criteria for deliver or emperor preserved, then we should give an SGLT2 inhibitor. If they apparently satisfy those criteria, we need to look to see, is there any particular reason why we shouldn't? And there may be cases that we shouldn't, such as amyloid or severe diabetes. And then if we decide to use the SGLT2 inhibitor or we decide we can't, then we look and we have to go to the next level of evidence, which is our clinical judgment of the hemodynamics. And then we try and optimize the hemodynamics. But when we have RV dysfunction, pulmonary artery hypertension, left atrial dysfunction, left ventricular diastolic impairment, interpreting the hemodynamics is actually very difficult. So the art of medicine comes in to get the right balance of vasodilators and diuretic agents to optimize the hemodynamics. There's no simple solution there. That's old-fashioned clinical judgment based on the patient in front of you.
Can
So
I
fascinating
ask
case.
Can I ask Dr. Febi to Prof. Enriquez? So will you start SGLT2 inhibitor if you have for the second case? Will you start
Yes,
SGLT2
I
inhibitor?
would,
Considering that
because
it's okay. Because
yeah,
you say that
I
it's most likely because of the SD closure, so I'm wondering, and it's not included in EMPA Preserve or in DAPA.
Yeah, I mean,
Studies.
I'd have to look back at the individual cases, but I think if they satisfy the inclusion-exclusion criteria for one of the two trials, then I would do it, because we honestly don't know the mode of action of SGLT2 inhibitors. It may be renal, it may be cardiac metabolic, it may be very diverse, and we need to give the patient the benefit of doubt. In all the sub-analyses of DELIVER and EMPEROR Preserved I've seen, there's no subgroup who's not responding well. So therefore, there's a low risk of side effects. The potential benefit is significant, not in mortality, but in prevention of heart failure hospitalization. So I would offer that. I think it's a relatively easy therapy to give.
Okay.
Yeah,
Thank
it's
you,
very
Prof.
Yeah,
Yeah.
even if we don't have, just like me, I don't have any opportunity to have a right heart catheterization for this kind of patients. So it's quite safe for us to give the SGLT2 anyway and treat him as the HFpEF patient, and then not see the outcomes of the patient. So many of the patient with the sign of symptoms of the short of breath and edema come to us already on furosemide or loop diuretic or spironolactons, but no improvement of symptoms. But I don't know. I need the opinion of this panel in here. But when the diastolic criteria meets, and then even though the NT-proBNP is not that high, and then once we give them the SGLT2 inhibitors and the clinical symptoms is improved. That's my clinical experience with SGLT2 in HFpEF. What do you think, Ezman?
No, I concur. I think you've got your diastolic grades and all that for echo, but actually they sometimes don't mean anything when it comes to a diagnosis of HFpEF. They just tell you the current state of filling pressures in the heart. So that's with regards to the echo, E's and E primes. The BNPs we know are useful when they're low, as Gary had pointed out in his talk, but they don't necessarily are high when you're facing HFpEF. We know about the BNP deficiency syndrome, etc., and all that in 20% of obese HFpEF patients. And there are many other reasons why BNP might not go up, or there are many reasons why BNP might go up falsely as well. I think with regards to the second case, I would say a wonderful case. And if anything, it's a reminder that even though the 2023 American guideline reminds us to look out for mimics for HFpEF, we also have to remember that there are a lot of ACHD patients now living to this age of 77, 80, and they're probably living with the common comorbidities associated with HFpEF. So we've also got to look out for HFpEF in this group of patients as well. So I think wonderful second case. I do have a question though about the first case, if I may ask. I don't know what to call it really. Is it a thyroid myopathy of sorts? Because there is an underlying thyroid disease.
Yes, it is correct. So I also wondering whether it's related to the thyroid or is it related to the hypertension as well. But I did the MRI, show that there's no significant fibrosis in the myocardium. So it's just a LVH. So I'm thinking that with the increase of the extracellular volume, so I'm thinking it's more because of the hypertensions. But somehow I'm pretty sure because of the patients has also atrial fibrillation that may caused by the thyroid as well. So I don't know whether
Yeah.
you all have any input. How do I define whether this is because of the hypertension or because this is because of the thyroid? I don't know, because we know that the thyroid can cause HFpEF. Hypertension can also cause HFpEF. So, and I treat both with the anti-hypertension, and also I treat with the thyroid medication as well. So I'm not sure which one that actually caused these patients getting well.
Yeah, no, I was just surprised because we saw that reversibility in the hypertrophy, and I'm not sure whether that's
Yeah,
something that
that's right.
I want to anticipate
That's
in
right.
my patients when they have this sort of
Yeah.
combination. So really a question to the panel, really. Is this something
Yeah.
that you guys have seen time and time again with SGLT2, or is it probably a bit of thyroid, but the SGLT2 probably is anyway indicated? So yeah.
If I may say, probably it's most likely because of the comorbidities as well, not only because of the SGLT2 inhibitor, because we know that the treatment recommendations for HFpEF, it's not only SGLT2 inhibitor and diuretics, but also treat the comorbidities. So
Yep,
most
true.
likely both of it can also help by these patients getting well.
Yep.
Yeah.
Thanks very much, everyone. Those are great discussions. I noticed one of the attendees has his hands raised. I just wanted to say we probably won't be able to hear the question, but if you could type the question, that would be helpful. We do have one question in the box, and I was hoping to perhaps direct this to either Gary or Hawani. And essentially, it's a tough question. I'm not sure if we'd be able to find the answer, but this is coming back to what you said, Gary, where we sort of the sort of more contemporary way that we think of HFpEF is a chronic cardiometabolic inflammatory syndrome. And in the context, I think, also the STEP HFpEF trial with semaglutide, what are the thoughts on the use of a GLP-1 in patients with HFpEF? That's the question that we have. Perhaps I might direct this to Gary and then Hawani, if that's okay.
Look, I must say, I apologies. I couldn't include the STEP HFpEF study in my talk today just because of time. But look, it's certainly something that I would consider, especially if you fit that specific phenotype of the overweight, obese HFpEF. I think in those patients, I do find that the effect is certainly is there. And I say that because in clinical practice, the way we have a few patients who are on semaglutide, dosed by their endocrinologists for a different reason. And we do find that, even though, we treat the HFpEF with SGLT2 inhibitors, you add on a GLP-1 agent, there is not much data about, the both of them. I think even in the STEP HFpEF study, there was only a small proportion of patients who were on SGLT2 inhibitors. But I must say, in clinical practice, they do complement each other quite well. So because of that, I think I would be more prone to use it. We certainly see obesity being very rampant these days. And, exactly like what Ezman had just said, some of these obese patients are really difficult to diagnose because their breathlessness is so non-specific. And they do have smaller than average, I guess, BNP levels. And in those ones, the challenge is always going to be there. What's your pre-test probability? What do you suspect as being the cause of the breathlessness? Just metabolic stamina, or is it just, do they really have HFpEF? And I think in this day and age, I think I being a heart failure physician, I look for HFpEF. So maybe my index suspicion is always higher than a GP or a different specialist. So invariably, yes, I do treat with SGLT2 inhibitors, and if GLP-1s, yes, I would say I'd go for it. Yep.
Okay, perfect. So worth considering and worth using, especially in the context of someone who is slightly heavy or slightly obese.
And I think the important thing is that it actually complements quite well, actually, I must say. I mean, look, I haven't had troubles with GLP-1 agents. They complement quite well with our other heart failure therapies.
Hawani, what about yourself?
Yeah, actually, I have a very limited experience in using GLP-1 receptor antagonists because it's quite expensive in Indonesia. And however, I do agree with Gary. We can use in limited populations like obesity patients, and of course, it's not as wide phenotypes that we can use as in SGLT2 inhibitor, because we know that in SGLT2 inhibitor, almost all HFpEF phenotypes we can use MPA or DAPA. So probably in a very limited population such as obesity. I couldn't agree more with Gary's opinion. Thank you.
Perfect. Yeah, and I do agree with what Vebi was saying earlier. Remember this from a symptomatic relief perspective, with all the HFpEF trials we have with the Emperor Preserve, with the Deliver. At the end of the day, a lot of the KCCQs, even after treatment, didn't go well roughly around 70, so still some way to go. It's about 6 o'clock, so perhaps you might move on to the final case if that's okay. So it's my pleasure to introduce Dr. Henry Chen, who is a cardiologist from Blacktown Hospital in Sydney, Australia, and he'll be providing the next case for us. So thank you so much, Henry. Over to you.
Hi, thank you. So this is the last stretch before the end of the day, I hope. Thank you for having me. So I'll be presenting the third case. So the last two cases have been more of a diagnostic issue. So thankfully I prepared a case which is more a management conundrum. I've got Mr. Robert Smith, obviously not the real name. He is a 72-year-old local forklift driver who's since retired. He is an ex-smoker and he has moderate alcohol intake. He had been diagnosed with heart failure with preserved ejection fraction around a year ago and has had recurrent rehospitalization over the last 12 months, around 3 from memory. He was only discharged a month ago and finally decided to attend the heart failure clinic. Of course, he had notable exertional dyspnea, he was orthopnic, and his lower limb edema has already come back. He's got New York Heart Association Class 2 symptoms, can barely walk up the stairs without gasping for breath. He's pretty good with his medications. It consumes around 2 liters of fluid a day, including 2 to 4 cans of beer. His GP's been struggling, his local doctor's been struggling with his fluid, and despite increasing doses of furosemide, his lower limb edema is not going anywhere. As you can see from his background history down here, on top of his heart failure, he's got hypertension, type 2 diabetes, long-standing atrial fibrillation, chronic kidney disease, and likely obstructive sleep apnea. Medication seen here, he's on beta blockers, nebivolol, metformin for his diabetes, dabigatran for his anticoagulation, and perindopril for his hypertension control. His furosemide dose is sizable at 80 milligrams twice daily already. On examination, he was very hypertensive with a blood pressure of 171 on 102. ECG showed atrial fibrillation with a heart rate of 92 beats per minute. He saturated reasonably well, had elevated jugular venous pulse, and had bibasal crackles on auscultation. And he had marked lower limb edema all the way up to his knees. He's a sizable man with a weight of 122 kilograms with a few kilograms of fluid on board and a BMI of 39. His echocardiogram from his recent admission showed preserved left ventricular ejection fraction at 63% with mild right ventricular dilatation. He had concentric remodeling and severe left atrial dilatation at 50 mils at index volume. His E-on-E prime ratio was not elevated, only at 8. His peak tricuspid velocity was assessed at 2.6 with a mildly elevated pulmonary pressure of 35, including right atrial pressure. His seropathology you can see here. He has stage 3 chronic kidney disease. His NT-proBNP is significantly elevated. He had elevated urinary albumin-creatinine ratio. His HbA1c and LDL cholesterol level is reasonably well controlled. So in this case, it's a pretty clear-cut HFpEF. He's got congestion symptoms. He got severely elevated NT-proBNP, and his left atrium is markedly dilated. Other than the relatively low E-on-E prime, he ticks all the boxes from both risk scoring systems. So how do we manage his fluid buildup? SGLT2, of course, is very reasonable. Reduces heart failure hospitalization, and he'll have a degree of natural recess to reduce his fluid buildup. But that by itself wouldn't be enough. He's already on a sizable dose of furosemide 80 milligrams twice daily. Yes, admitting him for intravenous diuretics is very reasonable. If those of you who has access to torsemide locally that has a high oral bioavailability might help. So in our case, we selected to use azithromycin. Thiazide is also reasonable, but that will drop the sodium further. Azithromycin as a bit of an extrapolation of the Advil trial, which used intravenous azithromycin, had a significant effect on diuresis, especially in patients with a relatively higher bicarbonate level, which Mr. Smith did have. We also started him on finerenone. Finerenone has been shown to reduce heart failure with hospitalization as part of a composite outcome in patients with type 2 diabetes and chronic kidney disease with elevated albumin-creatinine ratio. That's around 260 for those who use milligrams per gram. Yes, spironolactone may be reasonable as well for his diuretic. So we started him on digoxin to control his heart rate. And finally, for his hypertension, we elected to use hydralazine in combination with isosorbide, which has been shown to improve mortality and rehospitalization in the Veterans Administration trial all the way back in 1986. Note that isosorbide dinitrate was used in the trial, but unfortunately we only have isosorbide mononitrate in Australia. Of course, we have advocated for him to reduce his alcohol intake and keep to a 1.5 litre fluid restriction. So Mr. Smith was commenced on these medications and he came back a week later, 4 weeks later, sorry, a month later. There was significantly improvements. He lost 4 kilograms of fluid weight. His lower limb edema was gone. Blood pressure is much improved. Heart rate is now controlled with no significant reduction in his renal function. So now we have to move on to looking at how can we make sure he doesn't decompensate again. We gradually weaned off his diuretics onto a low dose of furosemide. We increased his finerenone to 20 milligrams daily. We referred him to a dietitian for lifestyle modification and weight loss, and referred him for a sleep study to assess for underlying obstructive sleep apnea. And of course, he should adhere to the nationally recommended vaccination schedule. Mr. Smith felt very good, so good that he decided not to come for the next few visits. His appetite improved, he was enjoying his life, and when he came back 6 months later, he looked like a different man. He put on 23 kilograms over the last 6 months, slight worsening of his dyspnea. He has no sign of congestion, thankfully. So now we're dealing with a metabolic syndrome, which is threatening to decompensate his heart failure in the future. His serum pathology demonstrates stable renal function, a marked improvement in his NT-proBNP. His urine albumin-creatinine ratio has also improved. And as a side effect of him enjoying life, his HbA1c and LDL cholesterol is now elevated. Thankfully, he did get his sleep study, which showed a elevated apnea per hour index of 24, and his oxygen desaturates to 79% overnight. So this is where we talked about some of the lifestyle modifications previously. So semaglutide, the Ozempic, we gave him more for his diabetic indications, or for his elevated HbA1c. We don't have the 2.4 milligram semaglutide here available in Australia, which was used in the STEP-HF trial. So we can't forget the other cardiovascular risk factors. He is classified as high risk, so his LDL should be as low as it can be, aiming for a target of less than 1.8 based on the latest 2019 APSC guidelines. And finally, he should be started on positive pressure airway therapy for his obstructive sleep apnea, which should improve his blood pressure control and reduce his sympathetic drive. We also discussed whether it will be worthwhile to achieve rhythm control for his atrial fibrillation. But given his rate control, it only has symptoms every time he's fluid overloaded, rather related to his atrial fibrillation. We decided that rate control would probably be more ideal for this gentleman. So in this case, we have to not just address the acute issues, which is the fluid overload, acute rate management, blood pressure control. We also make sure that they don't represent. They have to be educated for their own self-management, fluid control, and as well as their surrounding metabolic issues. So thank you for listening.
Okay, thank you, Dr. Henry. So yeah, from the case that we can learn how comorbidities can worsen all of the symptoms and how hard that comorbidities to be treated. And I noticed in here, as we treat the comorbidities and then the medical therapies list becomes very long. And as we know that in this kind of patient, the compliance of the patient to the therapy will be lower and lower. So the HFpEF itself and the comorbidities will bring a lot of homeworks, not for us as the physician and also for the caregiver and the patient as well. Any comments for this case, Prof. Enrico?
Yeah, and a fascinating case and all too common, I'm afraid.
Yeah.
Obviously, the disappointing bit was, what was it, a 24-kilogram weight gain from 118 upwards. So clearly that confounded the picture and raised more metabolic abnormalities. And then you had to move to a pharmacological treatment for weight excess with a semaglutide, which I clearly agree with, but it's a major tragedy that occurred. So the question is, what can we do with influencing with lifestyle medication, dietitian involvement, exercise training to do it, knowing how difficult it is? Because once you get that really excessive weight gain, everything else gets much more complicated. So this patient really has multiple problems to deal with, and working out which of the evidence-based ones is the really tricky bit. So we're trying to do our best, but ultimately weight loss is a critical part of this thing. If this patient's weight was 100 kilograms rather than 142, I think management would be a lot simpler. I'm not saying it's simple to get them from 142 to 100, but if you could do it, life would be a lot simpler.
Yeah, there's a thing that always in our mind about the fluid restriction itself. So the AST, interestingly, in the past month, published about the fluid restriction, with whether is it a normal or a restricted fluid restriction. There's some debate on this kind of fluid and salt restriction in a heart failure patient, particularly. I do realize that some European and American paper not to restrict anymore in a fluid restriction. They said that there's no difference in the chronic heart failure, especially to have a salt or fluid restriction, because there's no different outcomes in this kind of patient. But here in Asia, we add salt a lot, and we have a very hot weather in here, and then the fluid intake it's tend to be more than US or Europe. And Dr. Henry previously mentioned about the patient is not compliant with the fluid restriction. How do you think about this, Prof?
Yeah, look, the fluid restriction is very, very interesting. I mean, the overall trials that takes a large group of people and randomize to fluid restriction or not have been negative or neutral. So it's not a technique that works across the board. Having said that, we all have had patients where we know that fluid restriction and salt restriction in particular can be beneficial, because we've seen multiple times that if they have a high salt diet, they travel, they have takeaway food or restaurant food, they're more likely to get into an episode of fluid retention. So I think what works for an individual patient based on your observation of their response is completely different to a therapeutic strategy you apply to everyone with a disease condition. So I think that fluid restriction or salt restriction on average is not reliably going to work, but you know your patients better, and there will be patients in whom you know that asking them to restrict the salt or fluid will benefit. So that's clearly a sort of a clinical skills-based assessment. It's not a therapeutic regime. You don't say this patient has HFpEF, therefore I will fluid restrict, because that doesn't work on average.
Yeah, it's a personalized treatment, so it can be general. I do agree with that. So, any comment, Ezman?
No, I completely agree. I think at least in the ambulatory setting, we've done away with fluid restrictions per se, salt restrictions as well. But I guess in Henry's case, with having to add with such high doses of furosemide, having to add acetazolamide as well, probably it was reasonable to have a bit of a restriction in the acute stage. But towards the end, I think being a bit more lax about the fluid restriction really should be fine because there is really no evidence to it.
Yeah, thanks very much. Actually, it was quite an interesting case, Henry. You seem to be playing whack-a-mole with these comorbidities. Every time you finish with one, the
Yeah.
next one. I was very interested in the use of acetazolamide, as you mentioned, slightly off-label for sequential blockade. I do use it in the inpatient setting, but not in the outpatient setting with oral acetazolamide. Can I maybe perhaps open the question to the rest of the panel? Has anybody else had a lot of experience with acetazolamide on an outpatient basis orally?
Yeah, I do use acetazolamide for in an outpatient setting, especially in diuretic resistance. So, sequential nephron blockage, sometimes it's the only option for this kind of patient with the persistent congestion. But yeah, unfortunately, in my experience, I use acetazolamide for the maximum dose, three times 220, 250, and I check the serum creatinine in a 1 month, and then it will goes up. And as we know that the use of acetazolamide in a long term also can worsen the renal function. So if you want to push the patient into the sequential nephron blockage with several drugs, so yeah, we cannot close our eyes that the worsening renal function will occur. So I put him only in a 1 month, and then I try to ultrafiltration afterwards. So yeah, it worsened the renal function.
That's great. Something for me to think about. Maybe it's something I should try as well. The other thing that really interested me was your choice of finerenone for this patient. And of course, we remember the Fidelio and the Figaro trials. We know, of course, HFpEF is more commonly associated with CKD. And although the outcomes of CKD and HFpEF may not be as bad as CKD with HFrEF, coming back to this concept of obesity, we know that adipose tissue is endocrinologically active. We know that adipose tissue produces aldosterone, for example, and that seems to be the driver for inflammation and the endothelial dysfunction that we see in HFpEF. And knowing that, finerenone has both different genomic and non-genomic expression compared to spironolactone, the earlier generation steroidal MRAs. Perhaps it's a slightly unfair question to ask because this is all theoretical. But perhaps, Henry, may I just check with you, what sort of drove your decision to use a third generation MRA like finerenone? Was it purely due to the CKD, or did you think there was perhaps some activity from the HFpEF spectrum that was extrapolated from the phase 2 trials with finerenone in heart failure?
Yeah, so I think using a spironolactone first generation is quite reasonable as well. I'm extrapolating as well because the secondary outcomes from the TopCat was quite positive. So in his case, the main diuretic force was the furosemide, DAPA, and the acetazolamide. So the MRA doesn't add as much diuretic effect. So in his case, it came out last year. The trials were fresh in our mind. It fit the criteria perfectly. So I think in the end, we just decided to use finerenone in his case. There's no particular superiority compared to Spiro in the short term.
Oh, perfect. Thank you. So it's more you were considering the diuretic effect and the fidelity pooled analysis when you were making the decision.
Yeah, long-term effect.
Thank you. Anyone else has any comments? If not, I think we have a question on the queue. Oh, there's an answer.
I've got a question actually, and really it's to everyone, just based on Henry's case. Two things that struck my mind really when seeing the case. First was just weight loss from the get-go, but trying to obtain weight loss when the patient's all decompensated is very tricky. So I thought it was quite a nice timing when DGLP-1 was introduced, and then when was physiotherapy introduced, because you need that. But other sort of medications as well. Anyone would vouch for the use of sacubitril valsartan in this patient? Or in fact, I would say anyone would withdraw the nebivolol, a beta blocker, seeing that this is a HFpEF. Just trying to throw it out there.
I may go, if that's okay. I think the nebivolol could also be used for hypertension. You could potentially argue that. Of course, ANI is class 2B, it can certainly be considered. I thought, I certainly use ANI a lot in patients with HFpEF. One of the comments that I actually had, which I think Professor Coates went into earlier, so I didn't really go into it, was, in elderly patients, you're more worried about the weight loss and the weight gain. That said, a 23 kg weight gain is pretty impressive. And knowing that with semaglutide, the average weight loss in the clinical trial was 6%. So you might sort of argue that perhaps semaglutide might, it's sort of a drop in the bucket. You're not quite sure that you're going to reach a target weight with that. And I know he's over 70, but I was wondering whether you might be a bit more aggressive. Certainly in a patient like this, I might push him to my endocrine colleagues for consideration of bariatric surgery for a larger weight loss. I'm not sure if I'm being too aggressive. I don't know what the rest of the panel feel about that.
Yeah, the sacubitril valsartan and HFpEF, it's always interesting. So for me, to use the sacubitril valsartan, when to use the sacubitril valsartan is when I have the patient with HFpEF with intractable hypertension. So yeah, the sacubitril valsartan is very potent vasodilators. And then when I use the sacubitril valsartan twice 200 milligrams, and then the blood pressure will be normalized. I don't know. As Julian said that it's 20B anyways, then we can use maybe the sacubitril valsartan, even though the trial of the ARNI and HFpEF it's only a little bit missed the endpoint. But yeah, maybe if the hypertension is not treated well unless we give a lot of hypertension drugs, I tend to give the sacubitril valsartan to the patient, and then the blood pressure will be normalized only with sacubitril valsartan. So this is in Indonesian population. I don't know in Caucasian population. That's it, Ezman.
Yeah, I agree. I mean, there are a lot of things you could do because this person's got so many comorbidities, but a weight of 142 kilograms and such an increase, that gets in the way of almost everything. So I would like to make the clinical situation cleaner and easier to manage by reversing that 24 kilogram weight gain. So if semaglutide can do it, or if bariatric surgery can do it, if you can get the patient back down to 115, 110 kilograms, I think what's left over is much easier to manage. But to try to treat pharmacologically a person of 142 kilograms with sacubitril valsartan or SGLT2 inhibitors, you're really up against things because they're not really in the trials. We don't really know what we're doing in that case.
Yeah, I do agree with that. Okay, actually, we have one question that haven't answered by the panelists. It's from someone audience. It is interesting to see the patient with HFpEF have microvascular dysfunction. And then how often you send your newly diagnosed patient for a CAT and also check for a microvascular dysfunction? Maybe from panel. Ezman?
Well, quite a tricky question. I try not to CAF as much as possible. It is an invasive procedure. I also do believe that we've got quite good data now with regards to INOCA, MINOCA, and exercise stress test. And what I do is I try to incorporate a bicycle stress test if the patient has HFpEF, on top of just having ECG recordings as well to rule out ischemia alongside all this diastolic dysfunction when I'm feeling a bit fancy. But most of the time, I think I agree with Gary. If they don't have the symptoms per se of angina, I really do want to treat what's in front of me. Keep it simple, as Prof. Coates has said. I'm not sure what the others think.
Yeah, but something that most of our heart failure patients is having a dyspnea, and then they usually cannot do exercise stress test. Maybe we can have an option for another imaging option for to determine whether they have a coronary artery disease or that can be treated. And as we know that CAD also is one of the comorbidities. And we have another question in the question box. Most of our patients are CKD and dialytics, knowing they are excluded in the landmark trials. Do you give ARNI and SGLT2 inhibitors in this population? Maybe Professor Coates?
Yeah, it's really tricky. I mean, we have historically all the heart failure trials stopped at a GFR of 30, and we don't have any information below it. For most of the agents, ACE inhibitors, beta blockers, then we have evidence that they seem to have benefit right down to 30. So I think we're comfortable that we're not seeing an adverse signal. The only perhaps contraindication would be MRAs, the steroidal one, spironolactone or eplerenone, where potentially they're contraindicated with GFR below 30, but we now do have finerenone that's got better data. For the SGLT2 inhibitors and some of the recent heart failure trials, such as Victoria, they did push the GFRs down below 30, down to 20 or 15. So I think for those agents, we're much more comfortable going down to very low levels of renal function, including to the patient who's pre-dialysis. There is an evidence gap for patients on dialysis, but I think in some ways they're simpler because they're protected. So I personally am happy with a dialysis patient to treat them with all the treatments that work for heart failure. When the GFR is between 20 and 30, I am cautious, more because the patient's worried, other doctors are worried, and I restrict myself to SGLT2 inhibitors being the one with the best evidence base. But it is an area of missing information. We need to do trials in that area.
Yeah, any comment, Gary?
I think when it comes to renal failure, I think more and more we are studying, exactly like what Andrew just mentioned. It really comes down to also the your risk as well as your benefit, particularly if the context is suitable for you to push a little bit more. For instance, if you suspect that part of the renal failure is a result of a cardiorenal type of pathology, I would generally push a little bit harder as well. Specifically, differentiating HFpEF and HFrEF, let's put it that way. If it's purely HFpEF and what they have is a lot of the, I guess, the heart failure syndrome with repeated sort of fluid reaccumulation, and we suspected that it was predominantly driven by cardiac rather than renal, I actually would push a little bit more as well. Just for the symptom sort of improvement. And I guess you would need to have that conversation with the patient that, look, this would come potentially at the price of your renal function declining a little bit, but you would gain a bit more symptom improvement in that sense. I agree with Andrew when it comes to the dialysis population. Generally, I am actually quite aggressive with those type of populations, just because I think with the dialysis, I think your main concern is really whether or not you're actually going to get therapeutic benefit, because the medications tend to be dialyzed out. So yes, in that population, I tend to go a little bit harder with dosing in that population.
Yeah, agree. We have a renal replacement treatment already. So yeah, we don't really worry about the renal function. And we had a little bit discussion in a small group back then with Ezman also about the use of ARNI in dialysis patient. Maybe we might need your opinion in here, Ezman.
Oh, it's quite tricky, isn't it? Tricky area. I think I always just go back to whatever papers I have to support my argument. And I think there was a nice Journal of Cardiac Failure article about off-label use of sacubitril/valsartan, and the evidence really is in lowering NT-proBNP. Now, whether that translates into better outcomes, etc., obviously we don't know. Push comes to shove, a bit tricky. We sometimes do offer, but as Gary has mentioned, we will warn the patient about all the potential problems, etc. No issues if they're dialyzing, but if they're not dialyzing, then again, all the warnings need to be mentioned beforehand. Personally, I have used sacubitril/valsartan in these group of patients with not too much of an issue, but Outcomes wise, I have nothing to shout out about. Personally, I don't know about the rest. If you've ever used RNA and you've seen tremendous changes, even in terms of symptoms, etc. Julian or Gary?
I'm happy to go first if that's okay. I mean, I think personally, I mean, ESRF is one of those things that the patient population is very different, and things that we are useful for normal patients may not be as helpful. I always quote this example when patients with ischemic heart disease and ESRF, if you give a statin is very well established, but in ESRF, it seems to increase the risk of hemorrhagic stroke. And in the case of, patients with AF, there's very good evidence for NOAC in the absence of ESRF, but in the presence of ESRF, anticoagulation appears to increase the risk of bleed without decreasing the risk of stroke. I'm aware of one very small randomized control trial for beta blockers, and I think that was published in JACC in 2003 by an Italian group, and it was only about 100 patients. It did show a reduction in mortality and in heart failure hospitalization, but I'm not sure it has really changed practice too much. There's otherwise no evidence for randomized control trials in terms of RASI blockade, MRAs, or SGLT2s. ESRS were excluded from the four SGLT2 trials, sorry. And with regards, but there is, I remember, this same Italian group published a paper in JACC in 2010, and what they said was telmisartan added to an ACE inhibitor actually reduced mortality and also reduced heart failure hospitalization. But again, the concept of dual renin-angiotensin-aldosterone blockade has been shown to be harmful in multiple subsets. So again, I don't think that has really caught on too much. I think it's CICE, I think was the name of that guy. But it was quite an interesting paper, but I'm not sure that's changed practice.
Yeah, it's quite interesting. So it comes to the end, and I would like to thank you very much for our speakers and our panelists. And then don't forget to fill the survey to get your CME, and we'll see you later in the next heart failure teaching moment in heart failures webinar. Thank you. Bye.
Thanks everyone. Great, amazing.
Thank you all. Bye-bye.
Thank you all. Bye.
Bye.